This video is about critical appraisal of literature on harm. Once you find an article, the first step is to check the relevance. Are the objectives of the article relevant to your clinical dilemma? Compare the PCOM format of the clinical scenario with the PCOM format of the retrieved journal article. Are the PCOM formats similar? For a decision to stop the harmful exposure, the article must be designed to determine the harmful effect or outcome of the exposure to the patient or population. You do this side-by-side table. You write your PCOM for your clinical scenario and compare it to the PCOM of the journal article. Note that E here is exposure, not intervention, since you want to know if exposure to a particular risk factor is harmful. For methodology, there usually aren't any RCTs on harm because we are not ethically allowed to subject participants to a high risk of harm. Hence, studies are usually case control or cohort studies. If you see that the PCOM of your clinical scenario is too far from the PCOM of the journal article, if you see that the article you're appraising isn't relevant, you stop here and move on to the next article. You do not proceed to the next part or the validity part. This is a review of what a cohort study is. At the beginning of the research, you recruit participants into those who are exposed and not exposed to the risk factor, for example, smoking. Over time, you follow them to see how many will have and won't have the outcome, such as lung cancer. For case-controlled studies, at the beginning of the research, the participants are recruited based on whether they have the outcome, called cases, and those who don't have the outcome, called controls. Then we look back into their past, whether they had exposure to a certain risk factor or not. Once you have judged that an article is relevant to your clinical scenario, you appraise the article for validity. We have the following validity guides, these 5 questions, and we will look at them one by one. The first question is, were there clearly identified comparison groups? In the study, there should always be a control group, a group of subjects who do not have the outcome of interest, if case-controlled study, or exposure to a risk factor, if cohort study. Moreover, the comparison group should be very similar to the exposure group. Otherwise, you could have confounding factors, for example, age, comorbidities, ongoing treatments. Sometimes it can't be helped for there to be differences between the exposure group and the non-exposure group. So statistical techniques are used to adjust for those differences. The second validity guide is, were the exposures and outcomes measured in the same way in the groups compared? Measurements of outcomes must be similar in both groups of subjects. This ensures that surveillance bias is avoided or minimized. Surveillance bias happens when physicians who are concerned about a possible risk search more diligently and detect disease that might otherwise go unnoticed. Ideally, the outcome should be a very objective outcome that is less likely to be influenced by the knowledge of whether or not there is exposure. The third validity guide is, was follow-up sufficiently long and complete? Loss to follow-up can introduce bias because the patients who are lost may have different outcomes from those patients still available for assessment. For example, the reason that they may have dropped out is because they started feeling the ill effects of the exposure. So in order to be valid, the acceptable dropout rate is less than 20%. The length of follow-up must also be sufficiently long enough to detect the outcome. This requires some knowledge of the pathology of the disease. In prospective studies, dropout rate exceeding 20% may still be deemed valid, provided that intention to treat or worst case scenario analysis is performed by the investigators. Intention to treat is the same as worst case analysis, just different names. The worst case scenario is assumed, so the dropouts in the exposure arm are assumed to have developed the outcome, which is bad, whereas the dropouts in the control arm are assumed to not have the outcome, or no harm. Then you would check if this assumption would produce a different result for your study, if it would make a difference. The fourth validity guide is the temporal relationship between the exposure and outcome correct? And is there a dose-response gradient present? For an exposure to cause and effect, two important criteria may be considered. The exposure must precede the outcome, and a higher degree of exposure leads to a higher probability of the outcome. This would support the cause and effect relationship between the exposure and the outcome. Lastly, overall, is the study valid? Ideally, all answers to the previous four validity guides should be a yes in order for the study to be valid. If you have deemed the study to be valid, then you move on to the next part. If the study is not valid, then you should look for another article. Sometimes the best article that you can find cannot fulfill the four validity questions, but you can still proceed with the appraisal while carefully considering the results in light of the limitations of the study. Next, we move on to the results. When we look at the results, we determine the magnitude or the size of the effect of the exposure on the outcome. This depends on the type of study. Cohort studies give the relative risk, while case-control studies give the odds ratio. Usually, these are given in the articles and you don't have to compute it. Nevertheless, you should understand how these are computed and, more importantly, how to interpret them. Aside from magnitude, we also look at the precision of the estimate of the risk by looking at the p-value and the 95% confidence interval. We have this table with the exposure and non-exposure, and those with the outcome and without outcome. Remember, the outcome is a harmful outcome since this is a cohort study. Relative risk or risk ratio in cohort studies is the risk in the exposed group divided by the risk in the unexposed group. What is the risk in the exposed group? That simply means among those with exposure, how many develop the outcome? So that is A. So the risk in exposed group is equal to A over the sum of A plus B. Similarly, the risk in the unexposed means how many were harmed or with the outcome over all of those without the exposure. Then the relative risk is again the ratio between the risk in the exposed group and the risk in the unexposed group. Then how would you interpret whatever value you got from this RR? Keeping in mind the formula of the RR, you would understand that if the RR is greater than 1, that would mean the risk in the exposed is greater than the risk in the unexposed. Hence, the exposure is positively related with the disease or outcome. If the RR is less than 1, the exposure is negatively related with the outcome, or we might say the exposure is actually protective or beneficial. If RR is equal to 1, then the exposure is not related with the disease. Now let's go to case-control studies, which utilizes the odds ratio, not relative risk. Note that the odds ratio approximates the relative risk, especially when the outcome is rare. Odds ratio is computed as A over B divided by C over D, or for easy computation, A times D divided by B times C. The interpretation of odds ratio is the same as for relative risk. OR greater than 1 means the risk factor is positively related with disease or the negative outcome, and so on. It's not enough to know the magnitude of the effect of the exposure. We need to know if that result is precise. The 95% confidence interval means that you are 95% sure that the true value of the RR or OR lies in that range. The values of the 95% confidence interval should be more than 1 to say that the exposure really causes harm. If the values cross 1, 1.0, for example, 0.8 to 1.1, then we don't really know if the exposure is harmful or protective. Similarly, the p-value determines statistical significance, which establishes the actual relationship of the exposure and outcome, thereby eliminating the possibility of chance. A p-value less than 0.05 means that the RR or OR is significant. You can check either or both of the p-value and the 95% confidence interval to know if the estimate of the risk is precise. After you check the results of the study, you look at the applicability. Are the study patients similar to your patient in the clinical scenario? Compare the socio-demographic profile of the study subjects in the journal article and the actual patient. Determine if your patient also meets the inclusion and exclusion criteria of the study subjects in the journal article. Based on this, you ask yourself, should I attempt to stop exposure? In order to answer this question, you review the magnitude and precision of the risk of harm. And what are the consequences if the exposure is withdrawn? Make sure that withdrawing the exposure would not lead to an even worse outcome. Consider also, is there an alternative for the exposure? For example, are there alternative treatments, diets or regimens, or lifestyle changes? Finally, we have the resolution of the problem or conclusion. Based on the appraisal of the given set of data, what conclusions may be drawn? Use this to resolve the given clinical dilemma and apply it in clinical practice. You either decide along with the patient to continue or discontinue the exposure. That ends the critical appraisal for an article on harm. Go to the next video for the EBM user's guide to critical appraisal of literature on prognosis.